Welcome to EVMS UltraSoundbytes. I'm Suzanne Dickinson. I'm one of the ultrasound faculty here, and today we're going to be talking about the thorax, specifically the apical four-chamber view. Now, our objectives for today's ultrasound will be an introduction to clinical applications, as we always try to show you where to apply these in point of care, and also that this is going to be part of one of your go-to pictures for your EFAST. Also, we're going to go over machine setup and options, and we'll take you to the machine for that, as well as just talk about them a little bit. And we're going to talk about patient setup and acoustic windows. Patient setup is going to be a little different than the other two cardiac images that you have been viewing. And the acquisition of those images, we'll show you both on the patient and what you're doing at the machine. And some pitfalls and pearls, along with our SBI, our SBI scanning cards, and an SBI snapshot, which I don't have this list, but we will talk about an SBI snapshot as well. So for our clinical applications and for the purposes of doing this cardiac imaging, is you're oftentimes in point of care, you're evaluating for pericardial fusion, but you can also assess ventricular and valvular function for this particular view as well. For this, you have to consider the heart anatomy relative to the sound beam. Now, when I say heart anatomy relative to the sound beam, if you look at the drawn image to the left of the ultrasound image, you can see how the sound beam is pictured passing through first the apex and then moving to the base. And so the first thing that's going to appear on your screen, as the first thing that the sound beam touches, is going to be the apex. So your apex is going to appear at the top of your image. And the drawing to the right is showing that as a drawing, the same thing that you're seeing on the ultrasound image itself. Now, how that image is oriented, like I said, is because that sound beam is going to be hitting the apex first. So the first things that you should see should be your ventricular chambers. And so you'll see your right ventricular chamber and your left ventricular chamber. Then you'll hit the valves and move into your right and left atrial chambers. And also you want to have your depth going to be deep enough for you to even see those pulmonary veins. So that can be very useful too. And remember, from your parasternal long axis view, one of the things that told you where your left atrium was that you could see the descending aorta deep to it because it runs posterior to it. So it's one of the last things that the sound beam encounters, and so you should be able to see that descending aorta in that same orientation to the left atrium as you see it in its relative orientation, even when you're doing a plaques exam. So you also want to remember the sonographic signature of the anatomy. Remember, we would like to see a more anechoic chamber, but you'll realize that most of the time you're going to have a lot of acoustic noise in these chambers. They're not all going to be perfect images, depending on body habitus. All right, and last, when you're considering, you want to be sure you're considering your cardiac valves, because we want to be able to see how those valves are functioning, and you'll note that the tricuspid valve in its relationship to the mitral valve will be just a little bit more inferior to that mitral valve, and in the case of looking at it from this angle, it'll appear like it's a little bit more anterior than the mitral valve if you're using those as orientation. Machine setup, just remember that you're going to enter your information as instructed by Blackboard. Depending on whether you're in a specific module or whatever, your instructions on Blackboard will tell you what we want you to put in for the last name. It'll also tell you what to put in for the first name, which is usually the class you're in your year. Your probe selection is going to be the phased array, that cardiac probe as we commonly call it. Can you use other probes in a pinch? You can, but let's remember that the phased array is going to give us that small footprint so that we can get in between the rib spaces. Your preset is going to be a cardiac, and we're going to go to the machine and show you how to get to all of these things, although you've seen them in previous UltraSoundbytes. We'll just touch on them again quickly. And remember that your depth, focal zone, and your gain are going to be a default initially, and you want to leave it there along with your TGCs centrally and be able to adjust them as you go. Because remember, these presets are set for to consider all of those things from the get-go, but then the conditions of body habitus or even the windows that you're able to access will determine whether or not you need to change those depths, gains, focal zones, and TGCs. Now, here's where positional change from doing the plaques and the subcostal view can come into play. So the optimal position for doing an apical four-chamber view is left lateral decubitus. You can do a left posterior oblique or a supine, but if you want to really maximize that window and get that heart to fall closer to your probe, it's easier to have that patient up in LLD. However, that might not be always the clinical situation for you. But if you have the option, try it there first. And sometimes I will tell you that supine does work with a lot of folks, but you still may want to roll that patient up a little bit to get better views. Now let's go to the machine and I'll show you those steps on the patient probe, on the patient and the probe real quick. So when we go into the machine, let's remember that we want to, you got that one? Okay. We want to go ahead and remember that in our patient data, I'm pressing the patient data. This one is set for, already has a name in it. This just says Thorax 1, and maybe that's the what you want to enter depending on the module that you're in. And this example here just has the MPA 2024. So just reiterating that we're putting in last name, the module, first name, the class and year that you're in. Once you're complete with that, you can scroll down using your trackball to the OK button, and remember that your set button is like that left click on your mouse. Once you're here, now this is already set up in cardiac, but I'm going to show you that if we press exam, we've got our list of presets that we can choose from. And we're doing cardiac, and remember once we press that cardiac, what happens to our marker on the screen. So I'm going to set again, and note that our marker is going to be on the left side of the screen, or excuse me, the right of the screen here. So remember that that means that it's going to, what our probe touches, what our probe marker touches is going to be represented on this side of the screen. So the left chambers will typically be on this side of the screen here, and our right chambers are going to be on this side of the screen here. Okay, now as far as patient positioning, if we look over at our patient, let's go ahead and do an overhead. So I have already rolled our patient up on the left lateral decubitus position. I want you to note that his left arm is up, elevated up by his head, and he can just relax the other arm in the position that it's in. And what that does is rolls the anatomy in closer to our probe when we try to get our image. Now, I'm going to ask Atif, go ahead and lay flat for just a moment, a little more flat for just a moment. Now, the window, acoustic window on the patient is usually going to be below the nipple and about at the 5th intercostal space. So you know the heart is over here. So when you're placing your probe there, you are at that point of maximum impulse, and you're going to then move your probe to look across at the heart, and you're going to make contact with that apex first and then the base. So that's the concept behind it. So when he's rolled all the way up, it's rolling that anatomy closer to the probe and giving us a better shot at being able to get that image. Okay, let's give this a shot. You don't be afraid of putting plenty of gel, and you don't have to press particularly hard. You just have to feel your way. All right, now I've got a lot of gel on this probe, but I'm just going to show you. We've got the probe marker here. The probe marker on an apical four-chamber is going to point towards his left arm or left shoulder, or some will say the left axilla. The point is it's got to be pointing towards his left shoulder. So I'm going to place it right about at that fifth costal space, and we can already see some heart movement. Go here. And now we can see our apical four-chamber view. So I'm going to point out some structures, and you'll notice that we do have a lot of artifact in here. Don't be alarmed by that. In this apical four-chamber view, body habitus will dictate how well these chambers are going to clean out. And so we might show you images for the purposes of lecture of what the perfect image would look like, but for the most part we're not always going to get that image. But you'll notice that the left chambers are going to be on this side of your screen, as I explained, on the right side of the screen, and these right chambers here are going to be over on the right side. And that's by convention of the way that cardiologists like to see their echocardiograms. Now for the chambers on the left side, again, we're going to be contacting, the beam is going to contact with these chambers first. So we have the left ventricle first and our right ventricle here, and the interventricular septum running down the center here. As we move a little further from the beam, as the beam is reaching towards the base of the heart, we run into our valves. So between the left chambers are going to be your mitral valve, and between the right chambers is going to be your tricuspid valve, and you can see the valves moving, opening and closing with the cycle. Now getting further away from the sound beam as it approaches the base, now we're going to run into our atria. So again, we have our left atria here, our right atrium here, and then an interatrial septum right here. Now let me just get our view in just a little bit better here. I'm going to freeze an image. Now I've frozen an image because I also want to just point out these structures here as well. You have the pulmonary vein coming into the left atrium here. And remember that deep to the left atrium is going to be our descending aorta. So you'll see the descending aorta right here. I'm going to make this live again. Maybe. There we go. And if, unlike subcostal, we're asking a patient to take in a deep breath, for the four-chamber heart, we might even ask them to blow their air out. So I want you just to release your air out a little bit. And it may improve the image, but Ativ is just a really good example here. We didn't really have to do much for him. Go ahead and take in a deep breath. I want to show them what happens. If you ask them to take in a deep breath, your lungs are going to get in the way. I haven't moved. He just took a deep breath, let all the air out. And now we can see it come back into view. Now from this image, remember what we're looking for: the function of the valves. We're looking for any kind of pericardial effusion going around the pericardium, which you will be able to see here. We want to look at the global contractility of the left atrium here, and you can see how this muscle contracts evenly globally all the way around. Now if I laid the transducer back a little, let's see if I can get, not going to get that five-chamber view there. If I just drop the, I'm sweeping here, so I'm making the top of the probe move a little closer to his body, and you may not see it too well here. Let me freeze this, go back a little bit. By laying the chamber back, laying the probe, sweeping it back a little bit, I'm able to reveal the aortic valve here. That would be a five-chamber view, not the best image here, but I'm going to go back to sweeping, bringing my probe a little bit more straight so that I can get all of my structures back into the image here and see my chambers, my pulmonary vein, and my descending aorta. This is one of your go-to images before I go into pearls and pitfalls for the 3 windows that we've given you here. A lot of this will play into your FAST exam. So this is just another alternative for you when the other 2 windows are not accessible. And it's sometimes can be a very challenging image to get, but with a little bit of practice, it can be a very useful image to get. So let's think about just the usual things that we keep telling you. Don't start scanning until you have selected your preset and entered your patient information, because there is no anonymous scanning. Be sure that you position your patient optimally, and that would mean the left lateral decubitus position whenever possible. And I'll point out to you that even this position can be really quite useful for the parasternal long axis view. So if you're ever in a situation where the patient must be up on their side for whatever their injury may be, you can not only use this position for your apical 4-chamber view, you can use it for your parasternal long axis view. Now, don't be discouraged by the acoustic noise that you're going to get in the chambers. This is common depending on body habitus. You're going to get a lot of reverberation and noise from the surrounding lungs, and you may even get some side lobe artifact coming right through the middle of your chambers. And you're not always going to be able to clean that out. Just stay focused on what your purpose is for looking at this heart. You're looking at its function, you're looking at the valve function, you're looking at the global contractility of the muscle, the myocardium, and you're looking for pericardial effusion. And do take your time in manipulating the probe. I know sometimes in a fast situation we are, as even the acronym implies, we are under pressure of time. But the more you take time in your learning process of learning how to make those tiny little movements of heel toe and sweeping to open up the heart chambers, that's going to become memory movement. And so that when you are in a situation where time is of the essence, if you've put the time and effort to get your probe manipulation into your muscle memory, you'll be able to do these images rather quickly. You'll intuitively know how to turn that probe. All right, for our snapshot today, I want us to talk a little bit about side lobe and grading lobe artifact. And because this is something that you may see anytime that there's a fluid structure that you're trying to look at. Now, first I want to do a little review before I explain exactly what's happening with these side lobes and these grading lobes. Remember that the ultrasound machine is going to work off 4 main principles. It's going to think that sound travels in a straight line. It determines sound's going to travel straight away from it, and the echoes are going to come straight back to it. The echoes are going to originate from objects that are along the beam path. So anything in the way of that beam, well, it's right in front of that probe, so the machine is going to use that as a principle as well. Also, it's going to use as a principle that the amplitudes of the echoes are directly related to the reflecting properties of the objects along that beam path. Now, the distance traveled by the transducer and the reflector is proportional to that round trip travel time, which is based on that 13 microseconds per centimeter. Remember, that goes back to our rule of 77,000. So what happens is artifacts occur because these returning echoes violate the rules. Now, if we talk about side lobes themselves, we go, well, what is that? Well, we want to believe that we just have one central beam, but we don't. Depending on whether we have a phased array or a single crystal or multiple crystals, we get what are called side lobes and grading lobes. Grading lobes are usually associated with arrays. So on my image, you just see these little extra lobes coming out on either side of the sound beam. And so what happens when something returns from those? So when it returns, it's going to come back, even if it hits a very strong reflector, it's going to come back as a weak signal. Now, the reason why we don't see it when there's a lot of similar echoes around it is because it just blends right in. But if we see the signal right next to a water fluid structure, this main sound beam sees this water structure, it gets this weak signal from some stronger specular reflector by one of these side lobes, and so it places it right into the middle of the main sound beam. even though that's really a misrepresentation of where it is. And so that stronger reflector that is coming back to the probe by this side lobe makes this line right in the middle of our water structure. So this can be misinterpreted as pathology. Now let me show you what that looks like on an image. So if we look at this image of a bladder, this bladder is surrounded by stronger reflectors, and so that's why you have all of those grays. But right down here in this corner, you see these linear densities that are cutting across, and typically side lobes and grading lobes tend to be these linear densities that'll cut across. Now, if you'll notice up in the left-hand corner, I have a yellow arrow there. That's the frequency, and the frequency right now is at 5 megahertz. But one thing this isn't telling us is that, or rather it is telling us, is that I don't have harmonics on. Harmonics can be very useful in mitigating what side lobes and grading lobes can do. So if I show this image, again looking at where that arrow is, you see an H right in front of the 5 megahertz. And that is telling me I have harmonics on. So harmonics is listening to that second harmonic return from the main beam, and so is less inclined to listen to some of these side lobes or throw those signals out, and we're able to clean up the image that way. So if we look at the image of a gallbladder here, there are a couple of things going on in here, but our grading lobes are down here at the neck. We have a number of other kinds of artifacts in the fundus of the gallbladder, and that's mostly coming from reverberation coming off of the peritoneal fascia there. And if I again turn on our harmonics, you can see how clean it even took care of both of those problems that we had, right? So it took care of our grading and side lobes. It also took care of a lot of the reverberation interference that was coming from the peritoneum and the air from the adjoining bowel. So that's one of the tools that you can use when you're trying to mitigate these issues of side lobes and grading lobes. Now, your scanning cards are available to you on your blackboard, and these are for your badging. It'll give you these little reminders and guides in order to be able to acquire that 4-chamber view whenever you need it. I want to thank you for joining us for this episode of UltraSoundbytes, and we'll see you next time. Happy scanning.